Take two. What happens to someone when they get CPR in a hospital? Within the first 30 seconds, loved ones are ushered out of the way and CPR begins. Rescuers push down on the breastbone at a rate of 100 times per minute, which is about 2 per second. To be effective, we have to push so hard that the breastplate is pushed 2.5 inches into the body. Try to press down on your own sternum. Can you even press half an inch without discomfort? Now push it in 2.5 inches 100 times per minute. Compressions have to be done with such force that oftentimes the patient's head and limbs flail around like a rag doll. Many rescuers feel grotesque popping sensations in the person's chest. This popping is the cartilage that attaches the ribs to the breastbone breaking, and in some cases, the ribs themselves breaking. Studies conclude that at least 1/3 of CPR receivers have broken ribs afterwards. By the 30-second mark, supplies are brought into the room. Defibrillation pads are stuck to the front and to the back of the patient, and a backboard is placed underneath them. CPR is briefly stopped while this happens, hopefully less than 5 seconds, during which time the patient is violently moved from side to side. All of the clothes are stripped from the patient to allow access to the chest for CPR and to the groin so that we can check for pulses. By this point, the unconscious, completely naked patient is surrounded by at least 30 strangers. Family members, if present, are allowed to stay and watch. Ideally, there is someone there attending to the distraught family members, but that is not always the case. At the head of the bed, somebody is using an ambu bag to breathe for the patient. An artificial airway will be pushed into the throat to keep the passage open for air. If CPR continues, the patient will be intubated and hooked to a ventilator. If the patient does not have a catheter, they may lose control of their urine and sometimes their bowels. This creates soilage on the bed sheets that often goes to the floor. Sometimes a towel or a pillowcase may be haphazardly thrown over the mess. Blood or vomit may spew from the patient's nose and or mouth. Many caregivers wear masks and eye shields because of this phenomenon. These body fluids will spew forth at a rate of 100 times per minute in sync with the compressions. By the 2-minute mark, CPR will stop briefly so that the team can check for presence of a heartbeat and presence for an abnormal heart rhythm. If an abnormal heart rhythm is present, the person will be shocked by a minimum of 120 volts of electricity. The force of this shock will bounce the patient off the bed, again flailing their head and limbs. Following this shock, the entire cycle will repeat again for another 2 minutes. I've been in codes where this 2-minute cycle repeats over and over for greater than an hour. The longer the CPR goes on, the more likely that it will be unsuccessful. The in-hospital survival rate for patients receiving CPR is roughly 20%. And of those 20%, only 15 to 30% of them will survive to discharge. The room after the code often looks like an earthquake hit it. Depending on the number of body fluids that have spilled out of the patient, it can look like a murder site. If the patient hasn't survived, this is the room the family will be grieving in. Why did I say all of these things to you? Every single person who comes into the hospital is asked by a physician, if your heart were to stop, do you want us to do CPR? Take this question very seriously. At first it seems like a no-brainer. Of course, save my life, save my loved one's life. And does CPR save lives? Of course, there are CPR classes in every city across the globe. But in most cases, CPR cannot reverse the reason that the heart stopped in the first place. Did the heart stop because of cancer? Did the heart stop because of some other end-stage disease affecting your heart, lungs, liver, or kidneys? If so, the heart will stop again, and the entire process will have to be repeated. And to boot, CPR that lasts longer than 6 minutes can lead to irreversible brain damage. CPR is most effective for people who are at baseline relatively strong, whose bodies have a good chance of recovering from the violence they are about to undergo. Think the athlete who collapses on the field, the random person in a car accident, the accidental overdose or drowning victim. It is not intended for a frail 90-year-old with end-stage lung cancer and 20 other comorbidities. It may not even be good for a 40-year-old with end-stage cancer and 20 other medical problems. If you are concerned that CPR may not be a good idea for you or a loved one, please consider asking for a DNR. A DNR does not mean we stop treating you in the hospital. We still give you all of the therapies that are available to us. A DNR only means if your heart stops, we do not do CPR. That's it. So when a physician asks you if you or a loved one would like CPR in the event that the heart stops, turn around and ask them this question. Would CPR benefit me or my loved one given our current state of illness? If the professional treating you says it would likely not benefit you, please consider declining CPR. For most people who receive CPR in a hospital, these are their last moments on Earth. If you were told that CPR would not help you, would you choose to have your last moments look like this or like this?